So welcome back. Now today we'll be continuing the topic of pregnancy in those patients with autoimmune rheumatological diseases. But first, let's recap the blood flow in a pregnant patient. So remember, mom's blood collects in mom's venous system. It passes by mom's liver where it picks up nutrients. It goes to mom's heart. The blood is pumped to mom's lungs where the toxic carbon dioxide is removed and the essential oxygen is put in. It goes back to mom's heart and then it goes to mom's body. And in mom's body, it will pass through mom's kidneys, or some of it does in this parallel circulation, where the kidneys will filter and balance this blood perfectly. The blood also goes to the mom's uterus. That's where the baby is growing. And remember, the baby is attached to mom through this thing called the placenta, which is like a little patch on the inside of the uterus. And as the uterus grows, the placenta grows, and then the blood will go through the placenta, through the umbilical cord to the baby. The baby will use up what it needs. The blood goes back through the umbilical cord, back to the placenta, back to mom's uterus, back into mom's blood circulation, and then the process repeats itself. Now, a few things about a pregnant body, a few more things about a pregnant body. The first thing is that placenta does grow as the baby grows, and it's very complex. It's made up of a lot of little blood vessels, and it doesn't let really big things through and actually deactivates certain things or certain medications. The other thing is, though, it is very fragile, so it does clot easily. And the baby itself doesn't have some of the right things to activate certain medications, which means that you can give mom medications that will make it all the way to the baby, but the baby can't use those medications, so they just kind of come back unused back into mom's circulation. And as rheumatology doctors, we use this knowledge to better manage our patients during pregnancy. As far as why we are so careful with our patients with autoimmune rheumatological diseases who do get pregnant is, remember, what we learned is their complication rate is much higher, and not just from the disease itself, but also from some of the treatments that we are using to control their disease, and also because the mom's body is already being overworked, the liver, the heart, the lungs, the kidneys. And so our goal is to make that complication rate less and to not overwork the mom's body more than it has to be. So before pregnancy, when it comes to patients with an autoimmune rheumatological disease, as rheumatologists, we really like to see their disease be controlled for at least 6 months or more if possible. And we need about 3 months to pick different medications that are safer in pregnancy. And the medications we pick are going to be the ones that are bigger, so they won't go through the placenta, or they are deactivated by the placenta, or the baby doesn't have the right things to activate those medications if they do happen to make it all the way through. So we're just trying to be a little bit more safer for these patients. And when it comes to patients with the autoimmune rheumatological diseases who are pregnant, some of our medications do need to be started a few months ahead of time. Like, the body has to get used to it before it can be effective. Starting these medications in the middle of pregnancy doesn't really help. And we do also check some blood work before patients get pregnant and when they get pregnant to make sure that there aren't certain things in the blood that will cause problems in the placenta or the baby itself. And we do encourage our patients to find a good OB-GYN and a good pediatrician that will work closely with them throughout the pregnancy, but also work closely with us. Now, as far as what these patients need with autoimmune rheumatological diseases during the pregnancy itself, number one, we're trying to pick safer medications. So again, those that are too big to go through the placenta, are deactivated by the placenta, or not activated by the baby. Some medications we just have to avoid. And actually, some of our diseases do go into remission or become less symptomatic during pregnancy, like our rheumatoid patients. But then there are other diseases where the disease can actually get worse during pregnancy, like our lupus patients. This isn't for everybody, but for some patients, this can happen either way. which is why it's very important for our patients to remain in close contact with their OB/GYN and their rheumatologist, because sometimes our disease is flaring, or sometimes it's a pregnancy complication. It's hard to tell which is which, because both of them can sometimes cause high blood pressure, liver problems, or kidney problems, etc. So it's really important to be in contact with both set of doctors, if you will. And for our patients, usually the babies are monitored a little bit differently and maybe a little bit more closely in the last few months of pregnancy, usually that last 12 weeks. Now, as far as how these patients do rheumatologically wise after delivery. So in our patients with autoimmune rheumatological diseases, there are many medications that are safe to use during breastfeeding. However, if our patients, if their disease is flaring, they may need to be restarted on the medications that they were on before, and maybe not all of those are safe during breastfeeding. The baby is also monitored a little bit more through their pediatrician. Now, I know having an autoimmune rheumatological disease is hard enough, but getting pregnant on top of that, or having a pregnancy on top of that, can be scary, which is why it's better to be prepared for as much as possible. As Dr. Osler would say, the best preparation for tomorrow is to do today's work superbly well. Until next time.